we're just going to chat a little bit about labrum tears and whatnot. So from a basic perspective, what is the labrum?
Alright, so to understand that the joint, the shoulder joint, the glenohumeral joint, is comprised of a shallow dish with a large ball, and that's analogous to a golf ball on a golf tee. And that golf ball is very wobbly and it doesn't like to stay on that golf tee. So we were made with a labrum and a capsule that provides the stability. And the labrum is a thickening of the cartilage that goes around that deep dish, or that shallow dish, and it deepens the socket for that ball to sit on. And then secondly, it provides the attachment point for the ligaments that run from the labrum around and they attach onto the back of the ball. So it's a golf ball on a golf tee that's then kept there by a thickening of the edge of the tee called the labrum, and then a capsule which is like a bag that surrounds the entire joint. And those ligaments are at rest, they lax, but as soon as you take it and you stress it in various planes, those ligaments tighten up and they prevent your shoulder from dislocating. So if you take your arm out into this position, the anterior inferior glenohumeral ligament tightens up and prevents your shoulder popping out. And if you do that, then your posterior ligaments tighten up and your shoulder is not able to pop out of the back. Instability of the shoulder happens when either the T breaks or the labrum pulls off of the T, or those ligaments rupture. And then your shoulder then becomes incompetent. So you don't have the primary static stabilizers to keep your shoulder in place in those various positions. So when you take your arm out here, if the anterior inferior labrum and ligament is torn, there's nothing to prevent your shoulder from popping out, so it translates outwards.
So it's just holding the whole socket together.
It keeps the head of the humerus rotating very concentrically around a fixed point. But once you start getting tears and deficiencies, the shoulder wants to glide, whether it's forwards, backwards, up or out. The other muscles, the rotator cuff muscles and your deltoid, your traps and your pecs, provide secondary stabilization, but the primary static stabilizers is the joint congruity, your labrum, and then your capsule that makes up, or the ligaments that make up the capsule of your shoulder.
Okay. What's typically population group would you see with labrum tears?
There's a huge variation again in presentation. There are some people that are born lax.
Okay, so genetics.
You can look at their shoulder and it just wants to pop out. Or they can voluntarily pop their shoulder in and out. And then you get the big brutish rugby player who's never had an episode but lands up at the bottom of some ruck like this, and some guy jumps on the back of his shoulder and he tears the labrum. And then he has ongoing instability, even to fracturing part of the glenoid socket itself. There are recognizable patterns of injury. So the typical falling or forced abduction and external rotation stretches the anterior inferior ligaments, giving you anterior instability. And then the opposite, when you're going into a forced flexion, adduction, internal rotation injury with an axial force then when the shoulder wants to go out the back and the posterior capsule structures are damaged. So it would give you a posterior instability.
And in terms of tears, how would you grade them?
So you don't necessarily, well, you only grade the tears if you're getting some sort of radiological investigation. Clinically, you can comment on instability. So there's various different sort of nomenclatures. In the past, we used to talk a lot about the concept of AMBRI and TUBS. Okay, so AMBRI is an acronym that stands for atraumatic, multidirectional, bilateral, okay, and the treatment for people that have this type of a pattern, where they have atraumatic instability, so they haven't had any any trauma, it tends to be both shoulders, and it tends to be multi-directional. So you can pull them out the bottom, you can push them out the back, you can push them out the front.
Yeah.
The treatment for them is rehab.
Okay.
So you
Great.
rehab that person, you correct their scapular movement patterns, strengthen all their supporting muscles. And then the I of AMBRI, A-M-B-R-I, the I stands for, if you do surgery, you do an inferior capsular shift. So you take the whole capsule and you tighten it up the front.
Okay.
So that you stabilize the entire shoulder complex.
Yes.
As opposed to the TUGS, which stands for a traumatic, it's usually unilateral, happens on one side. The pathology is that of a Bankart tear. And a Bankart tear is literally where you just tear the labrum off of that glenoid rib.
Okay.
And the treatment for it is the S, which is usually surgical.
Okay.
Now there's again, all of those, there's a big variation and different people you're going to treat differently. But it's useful to think about, is this somebody who's just very hyperlax, they just genetically don't have very strong ligaments and their shoulders are wobbling all over the place, and they're having these repeated episodes of instability, and when they do a handstand or they try and do a bench press, they feel their shoulder moving around and it's uncomfortable there, well, they get rehabbed.
Okay. And
the first 9 treatments that you're going to do for them is rehab, and they come back to you, you're going to send them for more rehab, and only at the end, after failure of all rehab opportunities, then we say, okay, let's do some sort of surgery on you.
Okay.
Because remember, you're taking somebody who's genetically got dodgy collagen,
Yes.
and you're tightening them up, and all they're going to do is just stretch it out and get wobbly again.
Okay.
But hopefully you give them enough time with a good stable shoulder to correct their muscular imbalances and their movement patterns. After all these stability surgeries, they tend to go into an abduction sling. Even sometimes if we do posterior work, we put them into a gunslinger sling, so the arm pointing even more forward.
Okay.
As to further decrease the tension on the posterior structures. 6 weeks, but we tend to, unlike with the rotator cuff repair where we keep them very still, here we do passive movement from day 1, just to keep the arm supple and mobile and not too stiff.
Okay. And then when can they kind of return? So if that rugby player, when can you put him back on the field?
So with the lateral, what you're depending on is that little bone graft that you do. That bone needs to heal on, and that's not going to heal before 12 weeks. So I tell all the rugby players that have this, and anybody that has a lateral, that you've got to be first of all 6 weeks in a sling to let it bind down, get 30% strength, and then another 6 weeks of just getting your range of motion back. And if you've got good range of motion, you can start strengthening thereafter. In somebody who's involved in a non-collision sport, they can start about 4 months resuming normal activities.
Okay, good.
If they're involved in a collision sport, so rugby, water polo, 6 months.
Okay.
They've got to be prepared.
Yeah.
I don't think there's ever been any rugby player that stayed out of that for 6 months. But the advice is, until that bone is solid and you've rehabbed the muscles, don't go and stress that joint.